This morning, I'm really excited to introduce Dr. Pratha Sah. She is an associate research scientist at the Center for Infectious Disease Modeling and Analysis at the Yale School of Public Health. Her research uses mathematical, statistical, and network infectious disease models to understand how policies, human behavior, and the environment influence disease transmission. So I first met Pratha during a short course on infectious disease modeling in Seattle. The first summer I was in graduate school, I think. And we became friends discussing network epidemiology in animals. And I was really impressed by her at the time. I remember thinking how amazing she was, but it's been really awesome to watch her really become a leader in the infectious disease modeling field over the years. During the pandemic, she's led a number of really important studies to understand the impact of interventions, including border control measures, rapid testing, and vaccinations, as well as studies to understand the underlying epidemiology of disease, like understanding the prevalence of asymptomatic infections. I'm really excited to have her here, so please take it away, Dr. Sah.
Thank you, Spencer, for the very generous introduction. Let me share my screen. Can everyone see my screen? Yeah, okay. So hi, everyone. I'm so glad to be here and talk about some of my work on COVID-19. So today what I'm going to do is I wanted to share an overview of our research throughout this evolving pandemic. I'm going to talk about how public health questions changed as the pandemic progressed, and how our research pivoted to answer those changing questions. So before I jump in, I just wanted to take a moment to acknowledge our team members at Sigma Yale University and collaborators. So Dr. Syed Moghadaz is a professor at York University, and he has developed a complex COVID-19 epidemiological model, which has played a critical part in most of our COVID-19 studies. Dr. Alison Galvani is the director of Sigma at Yale University, and all of this work has been possible because of her leadership and direction. Okay, so going way back to where it all started. In January of 2020, we all started receiving news of a new virus that was causing pneumonia-like symptoms and spreading from humans to humans at an alarming rate in China. This virus was also causing severe disease among those infected, leading to high rates of hospitalizations and deaths. So the knee-jerk global response to this virus was implementing border closures and travel restrictions. There were also medical screening of travelers, and they were quarantined if they showed any symptoms. So at that time, there was limited understanding about how these restrictions were impacting the global spread of virus. We published a study at that time where we used reported case data in China and global airline connectivity data to predict the number of cases that were being exported from China with and without these travel restrictions. So we used disease characteristics that was known to us at that time, which is limited, to estimate the probability that an infected person would travel out of mainland China. We also estimated the country level risk of importation of such an infected individual. So in this particular figure, the x-axis is the initial timeline when these travel restrictions were being imposed. On January 23, 2020, there was a travel ban imposed in Wuhan, China, and on January 25th, there were similar travel restrictions imposed in other cities in the Hubei province in China. The y-axis over here shows the airline connectivity with China. So the countries that are up here had frequent direct flight connections with China, and the countries down here had infrequent direct flight connections with China. The points over here are data for 21 countries, indicating the date when their first COVID-19 case was reported. So we found a significant correlation between these reported dates and their airline connectivity with China. So we further found that um, the travel restrictions. Can you see this particular graph on the right, or is it just me?
I think we can see it, like the
Okay.
F panel.
Yes, I thought it was just my Zoom. Okay. So we further found that the travel restrictions decreased the daily rate of exportation by 81% during the first 3.5 weeks of implementation. So the bottom line of our study was that even though the travel restrictions were not completely effective at stopping the global spread of virus, they did create a delay, which was crucial to buy time to coordinate a public health response in other countries. Okay, so next our focus turned to asymptomatic infections. Asymptomatic infections exhibit no clinical symptoms throughout the course of infection. In the initial media reports and literature, these were often confused with pre-symptomatic infections. Now, due to this confusion over what is a truly asymptomatic individual and a surveillance system which primarily focus on symptoms, asymptomatic percentage has been incorrectly reported to be either as low as 4% or as high as 80 to 90%. We therefore conducted a systematic review and meta-analysis of the literature to estimate the percentage of SARS-CoV-2 infections that are truly asymptomatic. Now, we conducted this study because accurate estimation of asymptomatic percentage is essential to calculate key clinical parameters, project epidemiological trajectories, and optimize mitigation measures. Also, accounting for asymptomatic infections is necessary to interrupt community level transmission. So for our systematic review, we first developed a search criteria that identified papers reporting asymptomatic infections. We used the search criteria on multiple literature database and identified more than 114,000 abstracts. After excluding irrelevant and duplicate studies, we included 390 studies in our meta-analysis. Out of these 390 studies, 170 studies reported asymptomatic infections, which is they reported absence of symptoms at the time of testing, as well as no symptoms for at least 7 days after testing. So the figure on the right is the forest plot of our meta-analysis. I had to crop this figure because it was impossible to show all the 170 studies over here. The important point is that we found that 35% of SARS-CoV-2 infections are truly asymptomatic. Now, in our analysis, we recognize that symptomatic individuals are often overrepresented in the literature. So we explicitly corrected for this representational bias in our analysis. We also found that asymptomatic percentage was significantly lower for elderly compared with children. We further found that cases with chronic medical condition had lower asymptomaticity compared to cases with no underlying medical conditions. So the main message of our study was that asymptomatic percentage is substantial, although not as high as some of the reports. Also, since about 1/3 of infections are asymptomatic, it also means that symptom-based screening may not be sufficient to control community-based transmission, especially in daycares, schools, and universities that tend to have a younger population. So the next major event that we focused on was the spread of new variants. So around the time when vaccines were being rolled out in the US, we started getting reports of a highly transmissible variant, which sparked nationwide concerns about a potential resurgence of cases in the country. We published a study at that time that looked at the potential impact of accelerating vaccine rollout in the US to curb the spread of these new highly transmissible variants. So for this study, we developed an agent-based model of COVID-19 transmission and vaccination. This model was age stratified and incorporated age-specific disease risk and contact patterns. At that time, US was administering around 1 million vaccine doses per day. So we projected hospitalizations and death at this baseline rate of vaccination and compared it with accelerated campaigns in which daily doses was expanded to 1.5 to 3 million doses per day. Okay, so over here we see the results of our model projections. The top panel shows cumulative hospitalizations and the bottom panel shows cumulative deaths. Time 0 indicates the start of vaccination, and at time 40, we introduced a highly transmissible variant into the model. At that particular time, we had no idea about how transmissible this new variant was. So we looked at a variety of scenarios, ranging from the new variant being 10% to 70% more transmissible compared to the original strain. So our projection showed a couple of different things. First, it showed that the dominance of new variants was inevitable within a few weeks of introduction. It also showed that the pace of vaccination at that time, which was 1 million doses per day, would lead to a surge in hospitalizations and deaths as the new variant took over. We showed that accelerating vaccine rollout would substantially reduce the expected surge of hospitalization and deaths in the US. Okay, so the next major event, at least in my mind, was the July 4th milestone. The White House announced that July 4th, 2021 would mark the return of pre-pandemic life in the US, because at that time, COVID-19 cases and deaths were dropping dramatically, and the vaccination coverage in the US was increasing at a steady pace. So we wanted to see if science could back up this optimism. So we published a study where we explored if it was realistic for the US to safely return to pre-pandemic normal by July 4th. So the top panel over here shows a projection of daily incidence per 100,000 population in the US. The middle panel are our projections of hospitalizations, and the bottom panel is our projections of daily deaths. So let's just focus on incidence for simplicity. So I'll zoom in the next slide. Okay, so the black dot over here is the data of daily incidence from the US, and the black curve over here shows our model fit until May 1st, 2021. Now, let's just focus on the dark yellow curve over here. This models the return of pre-pandemic contact behavior for vaccinated individuals only between May 1st and July 4th. So during this particular time, we found a minimal change in daily incidence, even if vaccinated individuals reverted to their pre-pandemic contact behavior as soon as 2 weeks before their first dose. On July 4th, we projected outcomes under the assumption that everyone would revert to their pre-pandemic contact behavior. So, not surprisingly, we projected a sharp surge in COVID-19 cases, driven primarily by an increase in contact rates among unvaccinated adults and children. So the main message of our study was that US needs to adopt a cautious approach while updating their social distancing guideline, particularly because of the presence of these new highly transmissible variants. So this particular study came online a month after July 4th. By the time it was published, it was clear that our projections were unfortunately accurate. So the US did experience a surge in cases in the fall, just a few weeks after the July 4th milestone. Okay, so the last group of projects that I will quickly talk about today is the impact of vaccination campaigns. It may not be very obvious, but COVID vaccination drive in the US has been quite successful. Within the first year of launch, over 485 million doses was administered in the country, fully vaccinating 65% of the eligible population. By contrast, vaccination coverage of flu vaccine during 2020 season was only 52%. So, in the media and reports, a lot of attention has focused on the persistence of the pandemic and the hospitalization and death toll due to the virus. However, the positive impact of vaccination campaign has not been very obvious. So we've published a series of papers that has looked at the impact of vaccination campaign at the national level, at the state level, as well as at the city level. So these are a few examples of the studies that we have published so far. So today I wanted to highlight results from one of our more recent studies. Here we estimated the number of hospitalizations and deaths averted because of US vaccination program at its 1-year anniversary. So here again, we used our age stratified agent-based model. In our recent studies, we have added more details in the model, including the dynamics of multiple variants, waning of immunity, as well as booster vaccination. So with this model, we simulated pandemic trajectory under the scenario of no vaccination program and compared it with the current pandemic trajectory. So skipping to the good part, we found that within 1 year of vaccine rollout, the US vaccination program has averted more than 1 million deaths and 10 million hospitalization. It has essentially averted a healthcare crisis in the US, allowing businesses, schools, and other services to operate as normally as possible. Okay, so I will end today by mentioning a few projects that we have in pipeline. We are collaborating with New York City's Department of Health to assess the public health and economic impacts of their COVID-19 vaccination drive in the city. So According to our initial estimates, the vaccination program in the city has already saved over 47,000 lives. The economic benefits has also been tremendous. We estimate that for every dollar spent by the government on vaccination, there was about $60 worth of savings due to direct and indirect benefits of reducing disease burden. Okay, so I will end my talk and I'm happy to take any questions. I'll stop my screen share.
That was great. Thank you so much. And the work is just spans everything. It's been so impactful. I would love to hear a little bit about your experience in collaborating with, engaging with policymakers or decision makers, and sort of over the course of it, like in deciding what projects to take on and any, tangible impact you think these studies have had on policy, whether it's local, national or international.
Mm-hmm. Yeah, I think one of the more rewarding experience as an epidemiologist during this whole pandemic was trying to see how we engage with policymakers, throughout this course of pandemic, as well as media, and how do we sort of bring science to the forefront. So a lot of the times, the policymakers and media and even the Commonwealth organization that we've been collaborating with, they come up with very concrete questions that they want us to answer. So one of the major questions that they've been wanting to answer is the impact of vaccination campaign, both in terms of public health, how many lives saved, how many hospitalizations saved, but they've also been very interested in the economic impacts of on the vaccination campaign, right? Because ultimately it is about public health, but it is also about how cost effective this whole vaccination drive is. And obviously it has been very unprecedented at every scale, at city, national. So that's how our journey has been, trying to sort of answer the questions that they're interested in, and sort of we develop a model. We make sure that the models that we are developing are up to date, and the literature keeps on changing every month. So yes, just communicating with their needs and hoping that the science sort of like does justice to all of those questions.
Oh, that's really interesting. So with the sort of retrospective look at the impact and economics of the vaccines, which government agency do you guys work with? Is it CDC or is it and do you have a sense of whether that kind of analysis is informing like what they're going to be doing with boosters or future vaccination campaigns?
Mm-hmm. So right now we are collaborating with the New York City Department of Health. We were approached by Dave Chokshi when he was the health commissioner, and he wanted to get this messaging out that the vaccination drive has been very impactful, and I think that helps a lot in their communication to the residents that look, it has saved so many lives, and it also helps them to get additional funding when they say not only it has saved lives and hospitalization, but it has saved so many dollars. So the return of investment has been so much. So one of the main projects that we are doing is with them, but we've also been working with the Commonwealth Fund, and they've been more interested in the national level impacts or the impacts at multiple state levels. And the research that we've done in collaboration with them, a lot of our research has been picked up by the White House. So the national level results that I just talked about, I think it was communicated by the president, I think, and also by their at their press conference where they update on COVID-19. So yes, so they've been very interested in the work that we've been putting out.
That's great. Thanks so much for that. And actually, we recently got a very similar type of request from the Department of Health for the state of Texas. They basically are asking for retrospective analysis that validates their decisions and the impact of the various non-pharmaceutical and pharmaceutical interventions. I believe we actually pointed them in the direction of your paper as one really good example of this. But yeah, thank you so much. And I'll hand it to others for questions.
Thanks for the really nice presentation, Pratha. I was interested in the asymptomatic infection kind of meta-analysis, and I was wondering, I remember we did a similar analysis, actually, well, not similar at all, but looking at asymptomatic infections for Ebola infections a long time ago. And I was surprised that actually it seemed like asymptomatic infections for even Ebola seemed to be fairly common. And I wonder if, while you were looking through the COVID literature, if you looked at kind of any other infectious diseases, and do you think there will be kind of a changing paradigm in, infectious disease modeling overall, that like asymptomatic infections are fairly common over infectious diseases, and many of the studies are biased by the same kind of symptomatic detection process that seemed to be biasing a lot of the SARS-CoV-2 studies?
No, yeah, definitely. So this is something that I personally, I mean, even for when we used to do like flu modeling and stuff, I feel like asymptomatic infection has been ignored to a large degree, at least as far as my knowledge goes, because it sort of like flies under the radar. It's not detected through surveillance, and people don't show up to the doctors if they have asymptomatic infections. But given the fact that in for SARS-CoV-2, it's a substantial amount of people. It's 1/3 of people who have infection are asymptomatic. It has really brought this issue to the forefront that we should be accounting for this substantial proportion of epidemiology in our modeling. And it does make a huge difference about how we think about our mitigation measures, how we think about controlling community-based transmission. Because if you're just focusing on symptom-based screening and symptom-based, like testing, then it's going to be very difficult to control the transmission. So I think I wasn't aware about the Ebola issue, actually. So I think going forward, I think this is here to stay. Accounting for asymptomatic infections is here to stay. Yeah, definitely.
Thanks. Any other questions from the group?
I always have lots of questions if no one else has questions. But Pratha, I'd love to know. I mean, I'm familiar with your group, and I've had the honor of collaborating with you guys on some of these things. But I imagine, we're not in a school of public health, so we're kind of an island at UT, and we, have people from different disciplines. What was it like being in a school of public health? Particularly during the early days of COVID, was there a lot of coordination among the different groups? Did additional people kind of come in and collaborate with the Galvani group, or did you guys kind of just do your own thing, stay in your lane, and there was just a lot of other activity happening sort of separately?
So with respect to Yale, I I think we are sort of like a unique group, even though we are in-house in School of Public Health. I don't. Well, there are a lot of scientists and researchers sort of like working on different questions, but for our group, it's amazing how the dynamics sort of change. So, we have scientists and postdocs and research scientists sort of like working on different projects. So when we started working on these projects, like the questions and the literature was changing every month. So it's hard for one person to lead the whole project. So we've sort of like came together and we've been working as a group. So there's one person like Dr. Syed Mogadas, he has developed this model. So we've been collaborating with him very closely. And so he does some of the modeling part and he has his students. So someone collects the data, updates the model, someone runs the model, and there's another person who actually analyzes the results. And there's one person who writes the first draft, and then there's a team who sort of communicates, because communication is a big part of our projects right now with the policymakers or the Commonwealth Fund. So like as a group of collaborators and internal team members, we've like sort of like really come together. So I cannot say that this is my study. It's basically a group effort because we've been all doing our part, and that's how we've been able to have such a quick turnover of our projects.
Yeah, that's great. Thank you, Pratha.
Sure.
Actually, sorry, it's loud here in the morning. This is Jennifer Johnson Lung. I was wondering about the asymptomatic estimate actually, and if you've thought about how that's changed with the new variants, and also with, it seems, at least anecdotally, that people are having more and earlier symptoms if they have some prior immunity to the virus. Have you all thought about that at all?
That's a very good question. So when we published the study, we last updated our database on like February 2021. So that was still early days. So that was before new variants had really took over, and that was before the vaccination really kicked in the US. So now I would imagine that the asymptomatic landscape is much, much more complex depending on your immunity, vaccination-based immunity or natural immunity based on variants. Obviously, we know that certain variants are milder compared to other variants. So it's going to be very messy and very complex. So I wouldn't want to do this meta-analysis update because I would imagine it would be very complicated to figure out what's driving asymptomaticity at this point.
Thank you.
Sure.
Pratha, I have a question that I feel like we've been asked by the media quite a bit, and I've seen a lot of people on Twitter talking about it. I'm not quite sure how I feel, like if I have a strong opinion on it, but there's a lot of concern that the kind of surveillance system in the United States is being dismantled in some way that is going to make us more susceptible to future SARS-CoV-2 waves, because funding for like testing may be removed, genomic surveillance might be decreased a bit, wastewater surveillance might kind of lose some of its funding. I wonder how you think about all the different surveillance streams, and if you're concerned about, I don't know, like, potentially the decreased testing that we might have over the next few weeks, and how that might make us susceptible to future waves, or if it will make us more susceptible to future waves at all.
Mm-hmm. No, I definitely see a shift, and it's becoming tougher and tougher to sort of continuing hammering this point about how surveillance is still important, how vaccinations are still important. There's definitely a lot of pandemic fatigue going on. And as a personal experience, the people around me who are, who took their primary vaccinations, haven't taken their booster vaccinations, and now there isn't a very tough guideline on isolation or quarantine. So and then life can actually, I feel like apart from us, the life has sort of gone back to normal, even though we have a big pandemic going on still. So it's definitely very challenging. So we have to sort of think about how do we shift gears from a short-term pandemic perspective to long-term. How do we make this sustainable? How do we continue um, so having a surveillance system and vaccinating people at a sustainable rate? Is it's obviously people are going to get fatigued and exhausted and they would want to return back to their normal life, so there has to be a balance. And I guess that's how we sort of continue engaging with policymakers and figure out what's the long-term solution to that.